Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In this episode, we hear the latest hepatitis B data from the AASLD 2023 meeting. I'm joined by our expert faculty, Dr. Nancy Reau from Rush University Medical Center in Chicago. She'll discuss the latest data on current management of Hep B and also novel agents under investigation for HBV functional cure. For the full online educational program, including downloadable slides and video, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Reau has to say about the newest data on viral hepatitis, AASLD 2023.
It's always challenging to pick what we think are important presentations to cover. We try to do a mix of things that are currently relevant as well as those that are going to be relevant in the future. All right, we're going to first go over some of the current therapies. This is a summary slide of studies 108 and 110. So a randomized controlled trial that looked at either TAF or TDF for 2 years, with then a switch to TAF for all the individuals that are on TDF. That was a double-blind phase and obviously open label once you switched to TAF. This therapy was highly effective, but there were some individuals that did not respond. And so this current analysis is looking at markers or metrics that might help understand why people would not become virologically undetectable, described as a Hep B DNA less than 29 international units at week 384. And of course, missing individuals were excluded, as that was not going to be particularly helpful. Missing would not be a usable metric. So you can see on the left that both TAF as well as TDF then switched to TAF had very, very high efficacy with 95 to 96% under full virologic suppression. But there were a handful of individuals that were not suppressed. There were more E antigen positive, 33, compared to E antigen negative. And they did try to break these down to whether it was a blip, which is something that was positive, and then negative again, a virologic breakthrough, which was a defined increase in confirmed DNA greater than 29 after knowing that you were less, so suppressed and then broke through, or individuals that had persistent viremia. This would be someone who never became less than 29. And there were only 4 of those. And you can see that again, much more common in E antigen positive, and the most common would be a blip. It's also very important to highlight that there was a separate analysis, which we are not featuring, that showed that resistance was not a reason for any of these virologic failures or blips. So on univariate analysis, there were a lot of things that kind of were associated. Some might make sense, such as age, genotype if you're hepatitis B, maybe creatinine clearance if you're looking at toxicity or things like that. BMI, bone marrow density was also a factor, as well as female sex and Asian race. However, when you did a multivariate analysis, only a handful of things came out that were important. Those were genotype of your hepatitis B, that of course makes sense, as well as age. Now, it's important to recognize that these episodes were very infrequent. And I don't think that this data helps us change our management strategy. But if you do have an older patient, they are more likely to respond. And if you have someone who's hepatitis genotype D or A, those were associated with response rates. All right. We also had a lot of other information with that 8-year data. And I'm just going to highlight a little bit of it, a lot around the bone and renal toxicity or the bone and renal issues. We recognize that TDF does have some bone and renal signals that TAF seems to have more favorable. And this did bear out looking at the individuals with risk factors for renal or bone toxicity, which are defined here as age greater than 60, osteoporosis, a decline in eGFR, urine albumin to creatinine ratio greater than 30, or a low serum phosphorus. These were the flags for toxicity or risk. Among those that had at least one or more flags, serum bone markers of turnovers remained stable in those on TAF, and then decreased after the switch from TDF to TAF, and then stabilized, which you would imagine. So a fussy way of saying that on TAF, they were stable. With TDF, they declined, and then once the switch to TAF occurred, they improved and then stabilized. When we look at kidney function, the TAF did show a improved impact on eGFR and comparable to normal aging, so that there really was no renal signal on TAF. In those individuals that had the 2 years of TDF and then switched to TAF, there was a decline again in GFR, which improved after the switch. And the recovery was greater if you had one or more risk factors, which would make sense. But it's also really important to know that if you had one or more risk factors on TDF and tubular proteinuria, that this did increase during the TDF treatment and markedly improved after switch. And so I think that we would like to identify individuals that are at risk earlier than later and switch them sooner than later so that we can maintain and not or stabilize at a sooner time point, as if that in that bullet point here, you can see the TDF to TAF after 2 years was a better outcome than after 3. The next question, looking at TDF and entecavir, is a question around liver cancer risk. So this is something that seems to come up over and over, and it is difficult to answer in retrospective studies. So Kaiser Permanente looked at their very large, very representative group of individuals with hepatitis B, and they pulled out all of these individuals that were on TDF or entecavir for greater than 1 year between 2006 and 2021. And then they just used those that were adherent. Because there were significant differences in baseline criteria between the two groups, they also did a propensity score match cohort of nearly 1,000 people. And then they looked to see if that might influence outcome. So the overall cohort was a little over 3,300 individuals, with the majority treated with entecavir, 2,300 versus TDF, 1,026. And there were higher rates in the entecavir group of diabetes, hyperlipidemia, hypertension, and cirrhosis compared to TAF. The propensity match score was obviously going to be similar. And in both overall and propensity match cohorts, HCC screen adherence was higher with entecavir versus tenofovir. Virologic breakthrough rates were similar. So it's really important if you're going to get cancer, but you were not adhering to a screening regimen, that is more likely to be identified at a more advanced stage. So there, this is not perfect. However, when they looked at outcome, the unadjusted model was a little noisy, but the propensity match model showed that there was absolutely no difference in HCC or all-cause mortality between TDF and entecavir. And here you can see the things that they were matched for. So I think this gives us increasing confidence that if you wanted to use one agent over the other, but for one reason or another, whether it's insurance or patient choice, provider preference, the outcome should be the same. And so I do know that this will continue to come up, and maybe we will change our mind going forward, but at least in this large study, entecavir and tenofovir came out equal for mortality as well as liver cancer rates. But the next presentation I want to cover is early versus late postpartum cessation. So I know we already prompted you to answer this a little bit, but this was really trying to answer the question of how much of a tail of TDF after delivery. Is this important, or is this fine to just discontinue TDF at the time of delivery? So this is a single center prospective study. It still includes greater than 6,000 births of those with hepatitis B. The inclusion criteria did require the mother to have Hep B surface antigen at antenatal testing. And if you were Hep B DNA greater than 200,000 and you had normal liver enzymes and treatment naive. So kind of the criteria that we would use to identify someone that needed to take antiviral therapy to prevent mother to childhood transmission. They then looked at TDF, started between that 24 and 28 week and continued either until delivery or at least 1 week or more after delivery. And that would be late withdrawal. The primary outcome was virologic rebound, which is described as a 1 log increase after cessation. It is not the same as a clinical outcome or clinical relapse, which would require increase in liver enzymes. All right, so you can see here that the viral rebound rates were non-significant. So early withdrawal is in orange, late withdrawal is in blue, and the number of individuals that had viral rebound was nearly 100%. This is not new. We have demonstrated this before, but when you look at clinical relapse, which is the increase in ALT and the requirements for retreatment for clinical relapse, these again are not statistically significant. And when we look at birth outcomes, really birth outcomes are excellent as we would expect, and there was no difference in the retreatment-based strategy on time of withdrawal. So I think that this gives us the confidence to understand that we can stop Hep B therapy if it would otherwise not be used. So our guidelines for treatment are changing. But if you did not think that hepatitis B therapy was important for that woman at this time, You can stop it at birth, and we just know we have to monitor carefully after cessation for at least 3 to 6 months, because there is a very high rate of virologic rebound and a significant rate of clinical relapse, which could change your mind on retreatment. So no significant differences in viral rebound or clinical relapse rates versus early or late postpartum TDF withdrawal. So key points on current hepatitis B management and the covered studies. In the 8-year analysis of studies 108 and 110, which compared TAF versus TDF for 3 years, followed by an open label TAF, Hep B genotype A, Hep B genotype D, and age were all associated with not achieving full suppression or having something as a blip or a relapse. However, there was no significant association with treatment assignment or study drug adherence. And it is really important to emphasize the efficacy of these agents is incredibly good with 95 to 96% full suppression. Number 2, in a propensity matched Kaiser Permanente Northern California study, there was no significant difference in HCC and all-cause mortality between TDF and entecavir. So we did not see an advantage of one agent over the other for mortality and liver cancer rates. And then last, in a single center prospective study of pregnant women with chronic hepatitis B infection initiating TDF to prevent vertical hepatitis B or mother to childhood transmission, there was no significant difference in viral rebound or clinical relapse rates, timing yes, rates no, with early, which is at delivery, versus late, which is 1 month or later after delivery of postpartum flares or relapse. So we want to make sure that we are using these. I think these are 3 messages that we can use in our clinics going forward. All right. The next part of the presentation is on the investigational functional cure strategies. There was tons of excitement here. And again, there are lots and lots of presentations that we should pick from, of which we could only cover a minority. So we did our best to try to give you some of the high exciting information, although maybe not clinically applicable immediately. We hope that some of these agents will make it into our clinics. So there are 3 main strategies of achieving functional cure, and the purple ones are the ones that we're addressing in some shape or form in the presentations that to follow, and they can be combined. I think that most of us believe that you're going to have to use more than one agent and more than one strategy in order to achieve functional cure. Where there are multiple replication inhibitors, these include entry inhibitors, Hep B polymerase inhibitors, capsid inhibitors. There are ways of reducing antigen, such as Hep B surface antigen release inhibition, antisense oligonucleotides or siRNAs. And then there are multiple agents that are working on immune modulation. So just so you kind of get that sense that most of these studies will pair things from other classes, and we're going to try to cover a few exciting presentations. So the first is B together. This is looking at sequential Bepi or Bepirovirsen, which is why we call it Bepi, and pegylated interferon. So they used either 24 weeks of Bepi or 12 weeks of Bepi with a PEG tail, and then they looked to see what happened after treatment was stopped. These are all individuals who were suppressed on antiviral therapy, and they were continued on their nuke throughout the duration of therapy. The primary outcome was Hep B surface antigen below the lower limit of quantification and Hep B DNA below the limit of quantification at 24 weeks after the end of all therapy. So this is a little messy, but when you look at this, the 24-week Bepi arm is on the left, the 12-week on the right, and overall, all the things together are presented in blue. First column, second column, and third column are at the end of Bepi treatment, at the end of PEG treatment, and then at that 24-week post follow-up. And so let's concentrate on the primary endpoint, which is that 24-week post follow-up. And again, remembering the composite, or you need both surface antigen as well as DNA to be undetectable. So it's small numbers, but it is not zero. So 9% in the 24-week arm of Bepi and 15% in the 12-week arm of Bepi. But if you look at those that went into the study with lower amounts of hepatitis B surface antigen, so in orange, less than 3,000, and in green, less than 1,000, although the numbers are smaller, the efficacy is much higher, 24 to 41% in this group. Now, the numbers are small, so I'm not so sure that the 12 and 24-week Bepi is clinically important, but we definitely see that there is a suggestion that there might be some durable outcome in some patients. And it's important when we look at what we had previously known about Bepi. Both arms in B together had Bepi followed by pegylated interferon. No arm of Bepi alone, but that's okay because there was a previous trial called Be Clear that included either 12 or 24 weeks of Bepi alone. And this demonstrated that there was a significant improvement in efficacy from 3 to 9% in Be Clear to 9 to 15% in those individuals that had that PEG post Bepi. There was really no improvement in Hep B surface antigen decline with the addition of PEG, but there was certainly an improvement in relapse or Hep B surface antigen elevation. So this looks at ALT increases. So there are two reasons to increase your ALT. You can see during the Bepi period, the ALT increases when there's a decline in surface antigen, but in the pegylated interferon arm, ALT is well-recognized complication of PEG, and that was not associated with changes in surface antigen. You can also easily see from these graphics that during the Bepi period, there's a decline in surface antigen. There is no longer further decline in PEG. It's just that there is an improved maintenance over the Bepi treatment without pegylated interferon. And so there were transient increases in ALT in the Bepi time period that seemed to be associated with surface antigen decline. Safety, these are very well tolerated agents. You are going to have nearly 100% side effects, though, if you include pegylated interferon in anything. But there were really no treatment discontinuations, or very few that led to treatment discontinuation. And the overall efficacy here is quite good, not limited by side effects, many of which were just injection site reactions. We're now going to go on to the March Part B study. This is looking at VIR-3434 with VIR-2218 or PEG interferon. So you can see here that VIR-3434 is a FC engineered neutralizing human monoclonal antibody targeting the epitope of antigenic loop of surface antigen. So it's a monoclonal antibody that's supposed to have some degree of immune modulation. And they are using that with VIR-2218, which is a siRNA, or pegylated interferon, or some combination of these, which is, again, immune modulation. So the goal here is to decrease surface antigen with your siRNA, and then to boost it or to improve that immune response. And you can see that there is no 2218 monotherapy arm because that was already done. And the primary endpoint is safety, tolerability, and efficacy. And these were individuals with hepatitis B that were on continuous nuke therapy and did not have cirrhosis. So these were suppressed individuals that were then treated with a monoclonal antibody alone, or with an siRNA, or also with a siRNA and PEG. All right. So when we look at the data, remember what we're hoping to get is a decline in surface antigen. That's what your siRNA is doing, as well as virologic suppression. And here you can see that essentially no one in the monoclonal antibody achieved Hep B surface antigen loss, irrespective of baseline Hep B surface antigen. When you added the siRNA, you did have some degree of Hep B surface antigen loss at end of therapy, and that increased a little bit. Actually, it did not increase. It was the same if you added PEG. What is important, though, is so there was a 14 to 15% surface antigen loss, and then there were also some individuals that lost E antigen, and some of those that continued to maintain this. So when we're looking here for comparison, the siRNA with pegylated interferon only achieved a 5.6% surface antigen loss with 24 weeks of PEG, or 30% with 48 weeks of PEG. And so that's your comparator arm for that monotherapy. So this is a really nice slide. They're going to break down each therapy. So the monoclonal antibody alone on the left, the monoclonal antibody with siRNA in the middle, and then that combination with additional PEG and the most right-hand side, and looking at baseline, end of treatment, and then 12 weeks post, you can see that surface antigen loss was achieved in, or at least surface antigen less than 10, so very low level of surface antigen, was achieved in 40%, 70%, and 81% at end of treatment. But by post-treatment week 12, a lot of these had increases in their surface antigen. And although there was some maintenance in this low level, but most individuals rebounded. So it seems like it's an effective strategy at end of treatment, but it does not have some of the durability. But remember, these are our studies that are looking at things that we want to carry forward. We don't necessarily start them out correct. Tolerability and safety, again, is excellent for the therapy. It's going to be higher if you add pegylated interferon. And you can see here that there were very few grade 3 and 4 outside of the PEG-containing arm. So most of the side effects were, other than injection, were all related to the PEG. All right, our next study that I want to cover is REEF-IT. This is looking at J&J 3989 with 6379 with pegylated interferon. And now this study design is a little different. So for, reminder, 3989 is siRNA, 6379 is a capsid assembly modulator. So this is preventing, release of intact virus, and these capsids are released empty. Individuals enlisted in this study had active virus. So they either had to be treatment naive, or they had to have had a period where they had not been treated, and they had to have DNA greater than or equal to at least 20,000 international units, and a relatively low ALT. You couldn't come in really inflamed. And again, no cirrhotics. So that the first part of the study was using 3989 with with a nuke, and with or without 6379. And then they did that induction for 36 weeks, and then they added pegylated interferon along with this until the end of treatment, and then they watched to see what happened for 48 weeks. The primary endpoint was surface antigen seroclearance 24 weeks after discontinuing all treatment, which would be a functional cure. There are 54 individuals, 91% of which did reach week 24 follow-up. And it's important to know that 69% of these individuals were immune tolerant by definition, which means they had high levels of DNA and normal ALT at baseline. And that would be expected given what the recruitment criteria were. There were also very well-defined, rules in order to consider stopping your nuke. So remember, all the other therapies stopped. You really couldn't stop nuke unless you at the end of consolidation, unless your Hep B surface antigen was less than 10, you were E antigen negative, and your Hep B DNA was less than level of quantification, and your ALT was less than 3 times the upper limit of normal. So you really had to be a pretty darn healthy looking person with very well controlled Hep B in order to continue consider stopping the nuke. So these are the outcomes. You can see that this is looking at surface antigen that is defined both in thresholds, so the amount of surface antigen on the left, and then a decrease in log reduction from baseline on the right. If you look at the week 24 follow-up, this is kind of where you would hope to be. You're now off treatment, but you're still on your nuke. And the yellow bar is anyone that is less than 0.05 international per milliliter. And there were individuals that achieved this, 16.3%, 24 weeks after follow-up. But it's important to note that there was no patient that met the primary endpoint. One patient did meet nuke stopping criteria at end of treatment. By the time they were in that consolidation therapy or 24 weeks, they no longer met criteria for functional cure. So no one was really able to come off their nuke. 35%, though, did have an additional surface antigen decline with PEG, and of which some maintained this. So that when we look at the treatment, that this is an improved treatment now that you've added PEG over some of the historical data. So changes in surface antigen, E antigen, and Hep B DNA, as well as ALT. So 20% lost surface antigen. They had Hep B surface antigen seroclearance, and 6 of them actually remained negative at that 24-week follow-up period. There was a fair amount of E antigen loss, 28%, most of which was, again, maintained. So if you lost E antigen, that seemed to be a little more durable than losing surface antigen. And there was profound reductions in DNA, which you can see here, which remained in place even at week 24 follow-up, but not enough to meet all those criteria to allow them to stop their nuke. So there were substantial reductions in surface antigen, E antigen, and hepatitis B DNA levels, as well as cases of surface antigen seroclearance and E antigen seroclearance. And it's important because this is not the same as some of the similar studies looking at these agents. So whether it was a similar patient population, but a different course of therapy, or a similar course of therapy, but in a different patient population, they didn't see the same outcome. And this really implies that we have a lot to learn, and there is not going to be a one size fits all. But in this patient population, which was enriched in things that patients that look like immune tolerant, we did see substantial reductions in these factors, which is really important and really exciting. Safety was actually very well tolerated. Again, if you're adding PEG to something, you're going to expect AEs, but they did not seem to lead to treatment discontinuation. So I'm going to briefly go over another study that looks at VTP-300 and Nivolumab. This is kind of sounds scary for hepatologists who are not allowed to use Nivolumab for HCC, but now might be allowed to use Nivolumab for hepatitis B. I want to see what my oncologist tell me about that. But this is a study looking at VTP-300. This is a combination of a ChAd-Ox primer, and that's a chimp adeno primer, with modified vaccinia acaravirus, or MVA boost. So you give the ChAd-Ox and then follow that by the boost. And then Nivolumab. In addition, this is added to patients that are on nuke therapy. So these individuals, like most, with the exception of the study we just talked about with REEF, included patients that were well controlled on nukes. And you can see here that they looked at the dosing. Day 1 is your primer, and then the boost as at day 29 with low dose Nivolumab. One arm then going on to get another dose of boost and Nivolumab at 85. And then one had ChAd-Ox on day 1, the boost on day 29, and then Nivolumab on day 36. This assessment is looking at day 113, so it's not completely finished. This is an interim assessment. And then at the end point, you could discontinue your nuke if your ALT was less than 2 times the upper limit of normal, if your hepatitis B was non-detectable, E antigen negative, surface antigen undetectable, or surface antigen less than 100. So low-level surface antigen, non-detectable DNA, and essentially normal or near normal ALT. The primary endpoint was a 1 log hep B surface antigen reduction 6 months after treatment. So the primary endpoint was not going to be nuke discontinuation. There were 74 participants, and at the analysis of day 13, there were 56 to look at. So the hep B surface antigen reductions were most prominent in patients that started at a lower level of hep B surface antigen, less than 200. Now, this is important because remember the other studies that we were talking about where low-level surface antigen was important, drew lines at like 3,000 or 1,000. And so if we're going to have surface antigen rules, they might be very different rules dependent on the treatment that you're considering. So looking at surface antigen reduction at day 113, 23% had a 0.5 log reduction and 9%, or only 5 of the 56, a 1 log reduction or greater than 1 log. But if you cut that down by those that were less than 200 international units, 54, or over half, had a half log reduction, and 31% that of greater than 1 log reduction. So suggesting that this might be a reasonable strategy for hepatitis B surface antigen decline in those that have low levels of surface antigen. 7 participants did meet the nuke discontinuation. We'll see where that goes. And there were no significant treatment-related side effects. So the safety data looks very good. There were some transient ALT, AST, and thyroid function abnormalities, but these were expected. It's also, I want to call out that there was another presentation looking at VTP-300, so that immune modulating therapy following 24 weeks of imdusiran, which is a siRNA, and this also showed that there were very low hep B surface antigen levels maintained in the early post-treatment period. So, immune modulators with therapies that are also looking at other mechanisms are likely to be important to be considered. All right, so key points on our emerging treatments. B together was sequential Bepi and PEG interferon, in addition to nuke. 24-week post-treatment response rates were 9 to 15%, which is actually significantly over double the B together of 3 to 9%, which made a New England Journal. So it is noteworthy that surface antigen decline did not get better, but there was less rebound if you added the PEG. The March Part B, there was a threefold higher Hep B surface antigen loss at end of therapy with their Vir 3434 plus Vir 2218 plus PEG plus Nuke. That led to 14.3% compared to the other treatment options, although it was similar to the 2234 out PEG. And then in REEF-IT, J&J 3989 plus a Nuke added with or without J&J 6379 and PEG consolidation for antigen positive hepatitis B. These were active patients. These were not nuke suppressed, had substantial reductions in Hep B surface antigen, antigen, and Hep B DNA levels, as well as cases of surface antigen and antigen seroclearance. So very attractive, although they did not meet all of the goals that they would hope to. And then the last one is the HBV003, that this immune modulator with Nivolumab added to a nuke-suppressed treatment patient did lead to Hep B surface antigen declines in all treatment groups, much more pronounced in those that came in with a very low Hep B surface antigen.
Well, that was great, Dr. Reau. Thank you. There's a lot of questions coming in.
All right. So, Ahmed, I want to call out your question first. You asked, what are the patients in early versus late withdrawal of TDF after delivery? Were they antigen positive or a mix? And was there a separate analysis presented? So these are almost all immune tolerant individuals. So they're antigen positive, high viral load. That's what the standard, and that was kind of required. I do not believe that there were any antigen negative, but I believe that was commented on. And were retreatment rates higher in the antigen patients because most of them were antigen positive? We wouldn't know that. So I think that the vast majority of these were antigen positive, high viral load. On top of that, retreatment was really left to the discretion of the patient and provider. So some individuals that had clinical relapse were not retreated. And so I think maybe not retreatment, but rather the risk of clinical relapse is important because that's going to predict retreatment. And again, most of these were antigen positive. There is a question about AASLD and what do we know about Hep B guidelines? So I think there's a huge push to be more inclusive in our guidelines. And there was a great session for the WHO, kind of enticing us to realize that we were going to get new WHO guidelines, that they are nearly done, not yet released. I think that there's been some suggestion that there are going to be some alternatives for more permissive treatment. There was also a reminder that the Chinese guidelines are already out there, and they are very permissive. Really, anyone with Hep B DNA greater than 2,000 is eligible for treatment. And there was a strong age bias. Younger age could be observed, but at the age of 30, then treatment was recommended. And these are kind of similar to the U.S. Hep B algorithm, not the AASLD guidelines, but the US algorithm. And the AASLD guideline writing group was released. So we know that we're going to get new AASLD guidelines also. So stay tuned. They're going to make these great guidelines for nuke therapy. And then we're going to get all these new treatment options, and the guidelines are going to have to go back to the drawing board. One of the next questions I think is an important one to address is a presentation on the gray zone. So the gray zone in our guidelines are individuals that are Hep B DNA positive, greater than 2,000, but essentially near normal ALT. And there was a really nice presentation looking at a large group of these individuals that were either treated or not treated, and then biopsied after 3 years, and then biopsied again after 3 years. And those individuals that were not treated had progression to fibrosis, whereas those that were treated had regression of fibrosis. After 3 years, some of the untreated patients crossed over and became treated, and they again showed an improvement in fibrosis. So I think, again, that is a nice message which complements the Hep B guideline changes. What is the primary endpoint for novel drugs? So Ahmed, thank you for this. Is it functional cure or cccDNA cure? Well, I think it's going to depend on the novel drug. So if you look at something like Precision Bioscience, which is doing gene editing, they're going to be looking for sterilizing cure. I think most of the therapies are envisioning a hope to have Hep B surface antigen negative, even if we know that there might still be some degree of integrated or cccDNA. And if we can't get to that, the next hope is surface antigen positive, but no replication or very low levels of replication without any need for therapy. And I think the strategy really depends on the drugs they're looking at. So I think until we actually convincingly get one of those accomplished, which will then set a new line in the sand for all of the other treatment strategies, we're just hoping to be able to push more people into not needing treatment at all. So, Ahmed, on the basis of the relatively disappointing data from B-Together, March, and REEF-IT, do you think there is going to be any real role for PEG interferon in functional cure, or will other immune modulators really take precedence? I think that's a hard question. So the advantage of PEG, and PEG does have some, albeit relatively disappointing, improvement in lack of relapse. It is a readily available and very well understood drug. I think that Nivolumab makes most of us nervous, even if it has a great side effect profile in most. And then when you're looking at other immune modulators, I think there is always going to be concern about what you don't know when you're just looking at it in few numbers. I would say, though, like you're phrasing your question, that once we get one of these that looks like it's very safe and incredibly effective, PEG will go away. None of us really like to use PEG-related interferon, certainly not for anything greater than 24 weeks. And if you need 48 weeks of PEG, or you're trying to treat patients that have marginally compensated cirrhosis where PEG is never going to be an option, we would like to get rid of that agent. So we're hoping that the drug pipeline definitely allows it to go away. I can try to take one more question. There was a question about a nasal vaccine. Yes, so there was an anti-Hep B nasal vaccine, CVP, NASVAC. So it seemed relatively unpleasant. So it's every other week nasal vaccine for, I think, 18 weeks. Trying to get my own children to sit down and get the inhaled flu vaccine once a year is challenging enough. This seems like a lot of inhalation. But this vaccine really was very nice in decreasing surface antigen. And there was some degree of surface antigen loss, as well as anti-hepatitis E development. So this is a core antigen, surface antigen vector that is given in the nose, but there was very little impact on Hep B DNA. So small numbers, we'll see where this goes. And I think that strategies that are looking at vaccines, whether they're to be immune modulatory or treatment oriented, I think that this is pretty cool, but this may not be the right one yet.
Thank you very much to our faculty, and thank you to our listeners for joining in. To learn more about our coverage of AASLD 2023, including slides and video, see the link in the show notes. Please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.